Hello, everyone. Welcome. Thank you for joining me today. This is Jennifer Gross at PointRight. And for our final CEU approved webinar of 2020, we thought we would talk about VBP, value-based payment or value-based purchasing programs. So before I get started, just the usual housekeeping notes. All the audio lines are muted, so please feel free if you have any questions during the presentation. Just pop them in the chat and I will get to them if time allows, and we'll follow up by email if time doesn't allow. And also the handouts of this slide deck are attached to the GoToWebinar toolbar, so feel free to download those and save them for your own reference. So again, this is the ABCs of VBP. So it's been a while since we've kind of talked about value-based payment or value-based purchasing programs because events have gotten in the way. Both PDPM basically took up all our consciousness throughout last year. And of course, COVID-19 is taking up all of our consciousness this year, but VBP programs still exist. They're still running in the background. So we thought it would be worthwhile to give a refresher on this concept and bring you up to speed about what's been going on in the world of value-based reimbursement. So for this presentation, we hope you'll be able to come away with the ability to identify the key components of, in general, a value-based payment or value-based purchasing program. What's the kind of structure of the whole thing? You'll be able to explain how the VBP framework applies to a state Medicaid program. It's not just for Medicare. And think and apply certain strategies in your own organization to manage your quality outcomes and track towards improvement in those key metrics that a VBP program is measuring for. So let's start off at the federal level with the background. Of course, the oldie but goodie is the Medicare SNF value-based purchasing program. So we're going to start off with that. So what is the SNF VBP? So the whole idea behind value-based payment or value-based purchasing from CMS was the decision as the many OIG reports for over a decade had pointed to the fact that SNFs were largely reimbursed by the volume of services that they provided. The amount of therapy, in other words, that SNFs were providing was driving all the reimbursement, not everything else that was going on, such as the clinical characteristics of the residents or patients that they're caring for, and that's what PDPM addressed, but also quality outcomes. What comes out at the end of that rehab stay that you just got reimbursed by Medicare for, rather. So the idea behind the VBP concept is to incentivize better quality outcomes in post-acute care. And the ultimate goal, of course, is to reduce costs to the Medicare program and by extension Medicaid programs by improving quality. Because if you think about it, poor quality costs a lot of money between readmissions to the hospital, caring for things like a new pressure ulcer or a fall and a fracture. Those are expensive. So improving quality in the long run reduces costs and makes everybody a lot happier on the other, not to mention. So the legislative force behind VBP programs came about in 2014. We talk about the Impact Act that year a lot, but there's also PAMA, the Protecting Access to Medicare Act of 2014. And this was the legislative requirement for CMS to implement the first skilled nursing facility value-based purchasing program, or SNF VBP as we know it. And the program and this is the first component of a VBP that we're going to be focusing on here, is how it's funded. So SNF VBP, because there has to be money coming in order for there to be money to be paid out. It's basically taking the same money and moving it around. But the funding, specific funding for the SNF VBP program comes from that withhold. So a 2% withhold of all facilities who participate in the Medicare Part A program, 2% withhold of their Part A Medicare fee-for-service payments. So 2% off the top of your Medicare annual payment update. And then out of that, 50 to 70%, you can generically say 60%, but actually in the CMS documentation, it says between 50 and 70% of that withhold will be redistributed at the end of a program year as the incentive payments. And the rest is retained because the whole idea is to lead to savings to the Medicare program. So that's where the money comes from. Now let's talk about the measure. This is the next component of a VBP program. What is actually being measured? What's the measuring stick? So this is the SNF 30-day all-cause readmission measure, and CMS has multiple readmission measures. The SNF RM is what is currently in place for the SNF VBP program. So this is a risk-adjusted measure. So it takes into account the complexity and the clinical acuity of those patients. And it is an estimate of the number of what are called, referred to as unplanned readmissions to the hospital within 30 days of discharge from the prior proximal acute hospitalization. So basically, wherever it was that had that Medicare qualifying stay in the hospital, that is that prior proximal acute hospitalization. And the population, of course, since this is a Medicare savings program, is for your Medicare Part A fee-for-service beneficiaries. So not that your folks who, your residents or your patients who have opted to use a Medicare Advantage plan, they're Medicare beneficiaries and they're no less important than your Part A beneficiaries, but they're not part of this program because this is strictly to lead to savings for Part A. Now, your Medicare Advantage managed care plans, well, the managed care organizations are probably finding their cost savings elsewhere. But SNF RM is strictly for Part A beneficiaries. So the data source is from Medicare claims. So these are claims that are associated with that prior proximal hospital stay, because that time span is pinned on that, the 30 days out from that, the end of that stay. So it is a claims-based measure. So this isn't data that you at the SNF directly generate, but your outcomes will show up in this measure. So it's important to understand where the data is coming from. Now this could, because this is based on hospital claims data, this can and does include readmissions to the hospital that would occur after discharge to the SNF. So you have Mr. Jones who comes into your SNF, he stays for a little over 2 weeks for a uncomplicated rehab stay, he's discharged home to home care, something happens, he goes back to the hospital on day 19 after discharge from the hospital. That will end up counting towards your SNF RM metric because it's the hospital claims data. So it doesn't matter if that readmission happened from the SNF or from home care or from an assisted living facility after the SNF stay. It all ends up in the hospital claims database. And there are specific time periods that are being measured here. So this is another component that you need to be aware of for a VBP program. So the time period that is currently being measured for fiscal year 2021 that we're in right now, I'd say is, but it was fiscal year 2019, which was 2 years ago. And in addition, there's a baseline year. I'll talk about that in just a moment. Baseline years are used for comparison. So the baseline is fiscal 2017. So, remember, SNF RM was born in 2014, and since then, really, the clock started, I believe, around 2016. and has kept ticking all along, measuring every SNF in the country that participated in Medicare, and has been measuring their readmission performance all along. And it's retrospectively looking on how you performed for a baseline year compared to a performance year of 2 years later. So that's why you have to be aware of this, because what you do now will affect you 2 years downstream and 4 years downstream. So managing your performance now will pay off in the long run. So a SNF will end up with a performance score, which is the higher of one of these two measurements. So either it's your achievement score, which is how your hospital readmission rate compares to everybody else, or your improvement score, how you compare to yourself 2 years ago, or 2 years before the performance year. So that's why there's a baseline year, so that that improvement score can be measured. So even if your achievement score doesn't look so hot, you might be able to make up for that in your improvement compared to a prior year. So there's nowhere to go but improve, basically, in this area. So let's talk about what planned versus unplanned readmissions are considered as far as this program is concerned, because as much as we'd like to say, oh, they're all unplanned, I wouldn't send somebody out the hospital. Well, you rarely have planned readmissions for specific procedures, for example, so I shouldn't say that they're all unplanned, but most of them are unplanned. What is considered to be an unplanned readmission for the SNF RM program or measurement is something different entirely. CMS has what is called the planned readmissions algorithm, and this is a specific list of, and remember, this is hospital claims, so we're looking at hospital DRGs and procedures. So this is specific procedures or diagnoses from the hospital stay where CMS considers that a readmission would not necessarily be an indicator of a quality problem. It could be something that was, kind of baked into what you would expect to see for the course of care. So some examples, and this is not all of these diagnoses that are considered planned readmissions, this is just a sample, but things like transplant procedures, maintenance chemo, readmission to psych hospitals or psych units, anything pregnancy or delivery related, which most likely most of you will not have to deal with, but those are of course considered possible high readmission likelihood situations. So just know that what is considered to be a planned readmission versus an unplanned readmission doesn't have anything to do with your care plan in the SNF. It ties all the way back to what that diagnosis or what the procedure was from the hospital. So that's basically out of the SNF's control. Anything else is counted as an unplanned readmission and would count towards your SNF RM rate. Now, just a caveat here, because of the pandemic and the public health emergency, as with other quality measures in the CMS realm, data are being excluded from the current performance measurement period. Now, this is the latest information. I have no idea if this time period will be extended that's excluded, but for right now, from January 1st through June 30th of 2020, so the first 2 quarters of 2020 data are going to be completely excluded from the current performance measurement period. So whether or not CMS will decide to completely exclude 2020, I do not know. I did check again just to see if this had changed since the last time I had jotted this down, but it has not as of yet. But as we know, the public health emergency has been extended for a few times already, and unfortunately doesn't show any signs of ending soon. So let's talk about the payout, because that's another component of a VBP program that you want to be familiar with, no matter what program it is that you're participating in. So how are incentive payments distributed? How are they determined and how are they distributed? So firstly, the annual payment determination, your SNF will be ranked against other SNFs by your performance score. And remember, your performance score is the better of either your achievement score or your improvement score. So whichever one of those make you look better, CMS will take that one and rank you against everybody else in the country so that there's a distribution, kind of a bell curve. Any SNF that has the exact same score will be tied and end up with the same rank in that distribution. Then there will be payment incentive multipliers that will be assigned to each SNF based on their performance scores. So the best performers will have a payment multiplier that is greater than 1, meaning basically at the end of the year, you'll get your money back plus some. You'll get your 2% back plus a little bit more. The people in the middle who end up with that payment multiplier of 1 will just get their 2% back, but so basically no change in their original annual payment determination. And then the folks at the lowest end of the distribution will have a payment multiplier that is less than 1. So not only will they not get their 2% back, but there will actually end up being a penalty because there will have a bit of a payment decrease. Now, this is in decimal points. It's not, well, we're going to chop off 20% because you didn't do well enough in your readmission. But just know that there is a possibility that this VBP program might actually end up being a penalty in a certain sense because you end up with a payment decrease of your annual payment update for that fiscal year. So then the multiplier is applied to the payments for the services that are provided in the current fiscal year. So we are in fiscal 2021 right now, which, as I mentioned on the previous slide, your performance year was fiscal year 2019. Complicated enough? I hope you downloaded the handouts. Okay, so there have been no questions so far, so I hope this is at least give you an idea of the framework, even though the time periods and the dates are a little bit complicated, but it gives you the overall view of the framework of a VBP program. So CMS has also demonstrated the ability to jump right in and address specific critical challenges, not just for related to COVID-19, but if you think about a few years ago, how CMS started with those focus surveys related to dementia care and psychotropic medications and MDS accuracy, that they had identified areas that needed improvement and had started their focus there. So COVID-19, of course, is no different, both from the focus on infection control focus surveys, but also there is such a thing as a COVID-19 performance payment program. So let's talk about that for a few minutes. So the COVID-19 Performance Payment Program is intended to address the pandemic and SNFs. Of course, the SNF world has been fairly well devastated by the pandemic by providing incentives for infection control practices and lower mortality rates in the skilled nursing facilities. So the announcement of the COVID-19 program, performance payment program, was in August, and the program was announced, and then further details were released September 3rd. The funding, so where does the money come from? There were monies that were allocated in the CARES Act for specifically related to provider relief and support of practices to help reduce the spread and control the spread in provider settings, including skilled nursing facilities. So $2 billion of that was allocated from the CARES Act fund disbursement towards this performance payment program. So what's going to be measured? Next component, what are the measurements? The ability to keep new COVID-19 infection rates low among residents, and the ability to keep COVID-19 mortality low among residents in skilled nursing facilities. So the performance payment program as it stands right now runs from September through December of this year, and the performance periods are broken up into 1-month periods with a payout, one payout for each of these 1-month periods. So let's take a look a little bit more specifically about where the data comes from. So what's the data source? Understand how you're being measured and what is being used. So this is coming from the COVID-19 reporting to the National Healthcare Safety Network from the CDC. So this is the data that you have to upload weekly from your SNFs related to COVID-19 infections and infection control, PPE, staffing. There are a lot of rates and measures and numbers that you have to submit to the NHSN portal, but there are just 2 of those that are being used for this performance payment program. So first is your rate of new COVID-19 infections. So these are new infections that were not present on admission to the SNF, and now that resident has tested positive. And the facility rate of COVID-19 mortality, as resident mortality. Now that mortality rate is in fact risk adjusted using MDS data. So as with any VBP program, there's a level of comparison so that so who gets the payout and who does not get the payout can be determined. So every SNF's performance is measured in comparison to other facilities that have similar levels of community spread. I found this interesting that that the community spread is being used as a way to kind of stratify or group facilities to compare to each other, because as we have seen through many studies, over the last few months, SNF prevalence of COVID-19 is driven by the level of community spread of COVID-19 in the local community, which makes sense. So then the details here are that's about as much detail, unfortunately, as I can provide you, because I was doing some research. I was trying to find the details of, well, specifically how is performance ranked? What's the comparison? Are there cut points? What's the risk adjustment methodology? What elements from the MDS are used to risk adjust? I couldn't find any of that. I'm sorry. I wish I could, because that's you know, I don't like being able to not knowing everything about a program before I teach on it. But unfortunately, this has not been published as of this time. So that's really all I can tell you. So how the comparison exactly is done, and what the how the facilities are exactly grouped together by levels of community spread, and how the risk adjustment is done, we don't know, because it has not been published. So, but there's been a payout already. So the first payment distribution for September, that very first monthly performance period, was announced a couple of weeks ago on October the 28th. Now the numbers, depending on where you look, are a little different. There's the press release, Secretary Azar announced, and then there is the PDF document that is attached to that press release. You have different numbers on them, but between 9 and 10,000 plus facilities have received payment. Between 250 million and 300 million dollars. So it's a little bit of variability in the numbers, so I didn't want to put anything that's very definite on this slide, but I have a link to the announcements and all of that at the end of the presentation in your handout, so you can look this up yourself as well, to see specifically. The PDF document that's attached to the press release does break down the number of facilities by state that received the payment, but it doesn't list who they are. So you'll be able to look up your state and see, oh, there were 9 facilities that received the payment, but you won't be able to tell who they are. But at least there's something going out. Now, as you notice, this is not like normal programs that CMS rolls out with a great deal of deliberation and a lot of detail and comment periods and another comment period, and we're going to push this back. None of that happened here, which, you know, this is an emergency. So that's understandable. This program was implemented very quickly. So we don't know a lot of details. As I said, nothing's been released by HHS that I can tell of other than these press releases. So I think that it's highly likely that there are going to be changes to the methodology or clarifications or true ups if they're auditing to the program. I think it's very likely that we're going to see that, but of course it all remains to be seen because right now we are in the thick of it, kind of flying the plane and building it at the same time. Okay. Before I get to this polling question, let me just check and see. I see a chat message here. Oh, very good. Very good point. Thank you so much. There was a request to just kind of define fiscal year. Calendar year, we know what a calendar year is. It's January through December. And fiscal year, now it depends. Some states actually have different fiscal years, but as far as the federal government is concerned, in most states, a fiscal year starts October 1st. As we know, everything always happens on October 1st and goes all the way through September 30th of the following calendar year. So we are in fiscal 2021, which began October 1st of 2020, and it's going to go through September 30th of 2021. Thank you for that. I'm just glad it wasn't a hard question. Okay, so I have actually a poll, so I'm just going to launch that right now, and going to start that up right now. So my question is, has your SNF been awarded payment through the COVID-19 Performance Payment Program? And if you are in a multi-facility organization, then has at least one of your SNFs been awarded any money through this program? The answers are yes, no, I don't know, and I didn't know about the program until now, which I wouldn't blame you if you didn't, because there's been a lot going on. So I'm just going to leave this up for a little bit, and we'll see how many people respond. We do have some people who have received the payouts. That's great. Lots of people don't know. Again, I don't blame you. You've got a lot going on. And some folks actually had not heard about the program. So if nothing else, you learned something from this presentation. So I'm just going to leave this up for just a second. It's been about a minute. So I am going to close and I'm going to share the results. Okay. So we had 26% of our attendees, yes, did get some payout from the COVID program. So well done. Most people don't know whether they did or did not. Understandable. And 5% were not aware of the program until now. So yeah, for you know, your centers, everybody's participating that is submitting data to the NHSN program. So you're in it, and I hope you receive a payout, because that means goodness. It's all about value. All right. Very good. So we're at the midway point, and we are going to move into VBP with a state focus because value-based purchasing or payment programs are not just for CMS or not just for Medicare, although CMS has oversight, of course, and the federal government does contribute somewhat to state Medicaid programs, but states have really had a lot of flexibility to put in place their own programs that drive towards wherever their quality priorities are for that local population. If you are in Wyoming, you're going to have very different priorities as far as what quality initiatives are needed for your population in your state versus, let's say, South Carolina or New Jersey or Massachusetts. So every state who manages their own Medicaid program, which pays a very large proportion of skilled nursing facility and nursing home stays, they're looking to save costs as well, and Medicaid margins, of course, are a lot smaller. So we've seen VBP programs up and running for quite a while in states. Off the top of my head, the ones I've had the most exposure to have been the QUIT program in Texas and the QUASP program in California. But we have another program that we're going to be talking about that is just in the process of getting off the ground. So first of all, let's talk about the general concept of VBP programs with a state focus. So there is an arm of CMS that is the Center for Medicare and Medicaid Innovation, or CMMI. So this is an area of CMS that kicks in federal backing funds to help states put in place programs to improve care and reduce costs. So another piece of this is state innovation models. So this is basically an area where states can learn from each other, but also compete for additional funding and support for their cost-saving and value-based payment program models. So there's been a couple of rounds of the SIM initiative, and for both rounds, there have been awardees in 38 states, 3 territories, and DC. Actually, I'm not sure if that was 3 territories or if there are more territories that have received funding. But regardless, this has been going on for quite a while, and you might not even notice it because there's, of course, always all kinds of programs going around. But you may very well be currently participating in your state in a VBP program without even knowing that it's a VBP program. So, of course, it's all about improving value, improving quality to save costs. And in this case, we're talking about cost control, not just for Medicare and for your dual eligibles, but for Medicaid services and for CHIP, for the services related to children's health, and preventing negative outcomes, which of course cost money. So we're going to be talking about a new program that PointRight has been involved with in New Mexico. So our friends in New Mexico have developed a program called the Nursing Facility Value-Based Purchasing Program, catchy name, NMVBP for short. So what this is a program with a goal to, as you can see here, their mission statement or their goal is to improve the quality of care, reduce avoidable hospitalizations, and optimize health for all New Mexico Medicaid members receiving services in nursing facilities by 2023. So great goal. And again, improving the quality care and reducing avoidable hospitalizations and optimizing health all results in savings to the state Medicaid program. So that's the goal. What's the measurement? So the data source, the primary data source that is being used in the NMVBP program is MDS, which is always very good to know, because the value of this for any program, any measurement program, is that this is data that SNFs are already producing day in and day out. That limits the amount of additional reporting that SNFs need to compile. Just one other thing that you need to upload to the government. The less that a program can do that, the better. And again, facilities are being ranked against each other or tiered based on the statewide comparison group. So this is truly comparing amongst peers. And there is an additional add-on for a specific subset of diagnoses that have been determined to be high acuity for that resident population. So There is also a secondary payment component to incentivize certain care processes and practices. And I'll get into the specifics of what we're talking about in just a moment. But this is how these are the components that, again, you need to be able to tease out whenever you're thinking about or learning about a new program. What's the goal? What's being measured, and what's the data source that is being used to measure? How is the payment structured? How is your performance being determined in comparison to others or in comparison to yourself? So the funding mechanism, where does the money come from, is another thing you need to know. Now, this can vary between states. For the specific NMVBP program, this is funding that was allocated specifically in the state budget for this program. So this is not something that comes from a facility surcharge or a bed tax that all the facilities in the state that participate in the Medicaid program have to kick in to the kitty in order for it to be paid out in a program, because that is something that can often cause a lot of controversy among the provider community. This is something that's already been carved out in the state budget and put aside to be used for this program. So the money ultimately kind of comes from the same place, from the state tax base and from the program, but at least it's being carved out with minimal pain to the provider. Now, one thing to keep in mind with New Mexico is they do have a managed Medicaid system, and there are 3 MCOs that disperse the payments. So the MCOs are going to be the ones that are actually doing the payout in this program. The MCOs themselves, of course, are all about care management because they're managed care organizations, and their goal as entities is to manage care to not only improve outcomes, but also to reduce costs to the MCO and ultimately to the Medicaid program. So this is actually an optional program, unlike the CMS programs, where if you're participating in Medicare Part A for the SNF RM, the SNF VBP program, or basically if if you're doing the reporting on your COVID-19 data to the National Health Safety Network, you're in the program. This program is actually optional. SNFs can, or nursing home facilities can choose to enroll, and that enrollment period is 2 years in this program. And then at the end, you can disenroll if you want to. You have to give enough notice. But then at the end of the 2 years, you could choose to enroll again. So it's at least kind of has that voluntary component to it. But in order to be eligible for the program, the facility has to be contracted with at least one of those MCOs. Now, the performance measures will be evaluated throughout this first 2-year performance span, this first 2-year enrollment period, and it is possible that the performance measures that I'll be talking about next, they might be revised after the initial 2-year period, and other measures may be selected, which a good program will have that flexibility to say, okay, this measure, we've improved all we can here, let's move on to something else. So what are the performance measures? So we have MDS-based quality measures. These are the ones you know and love from your CMS quality measures, and that you can access in your PointRight application. So 3 of them are CMS defined measures: long stay antipsychotics, UTIs, and pressure ulcers. And then they also use the PointRight Pro long stay measure, because this is an MDS-based measure of long stay hospitalization. So A, it's MDS-based, B, it's risk adjusted, and C, it's relevant to the long-term resident population, i.e. the Medicaid population. So that's why prolonged stay was chosen as the utilization measure in this group of 4 quality metrics. But it's just those 4 from the MDS data. As I mentioned earlier, the facilities are ranked against each other statewide and put into performance tiers. Each quality measure, the facility can get up to 100 points for best performance. And for the program max, of course, that adds up to, for 4 measures, a total of 400 points that can be garnered from the QM component of the NMVBP program. So the performance ranking, again, all the facilities in the state that participate in the program will be ranked against each other on a curve, and there are cut points so that the facilities are placed into tiers, with the folks who are performing better in a quality measure in the upper tiers with more points per QM, and the facilities that are performing lower will receive fewer points. But this is per quality measure. So, for example, if you perhaps are struggling with your long stay antipsychotic rate right now, but you're doing pretty good in your UTIs and your pressure ulcers and your long stay hospitalization, you may be able to make up some points that you were losing in your tier ranking for antipsychotic. So the components for the financial incentive, there are actually multiple components to how the money gets paid out. So again, if a center is not doing so well in one area, that doesn't mean they get nothing. There is still the possibility to get something from this program. The folks at the state who were developing this program were very keen to make sure that it wasn't just only benefiting the folks who were the best already, but doing their best to help everybody improve. So first of all, there's a foundational payment that's paid out on a quarterly basis, and this is to keep folks participating and also to defray some costs to participate in the program. And that is tier adjusted, so you do better, you will receive more. Then there's a secondary quality payment. I mentioned earlier there's a secondary component that is used to incentivize facilities to participate or adopt certain behaviors or practices. This is paid out once a year, and the one for calendar year 2020 is for using telemedicine, which is very apt this year. And then there's the tier percentage quality payment. That is the one that is tied to QM rates. And your tier performance, every facility is eligible to receive up to the full per diem rate for that facility. And then the tier performance may adjust that downward based on their points. And then it is paid out as a per diem rate times the Medicaid bed days for your facility. So it also comes down to if you have relatively few Medicaid bed days, then your total payment will be lower because the per diem rate will be distributed for fewer bed days. And then lastly is the high acuity add-on payment. These are specific diagnoses that are determined from Section I of the MDS for these residents, and they have to do with mainly very complex psychiatric issues and neurological issues that the state and the provider advisory team that were working on this program found to be high priority in the state. So multiple areas where a facility can realize some funding through this program. And then the payment structure, as I mentioned, there are quarterly payments for 3 out of the 4 components, except for the telemedicine piece, which is yearly. Now, for each quarter, remember the facilities are doing their MDSs, and they want to make sure that their MDS data for the quarter is submitted and also corrected if there are any errors that need modifications. That time period to do that closes 30 days after the end of the performance quarter. So if you're participating in a program, that's a date that's very important to be aware of. Then the payout is tier adjusted. It's a per diem payment that is applied to the number of Medicaid bed days within that quarter. So it's your bed days times that per diem rate times your tier percentage. So if you were eligible for your per diem rate, but your tier percentage determined that you could only get 75% of that, that is what you will receive for those Medicaid bed days. And remember, this is the additional VBP program payment. So it's not a penalty. It's not lowering your Medicaid rate. It's just potentially lowering the total amount that you could get from this program. Now that high acuity bed day add-on will be redistributed. So basically there are program funds that are already allocated for this. And if there are any leftover funds from what was allocated for the quarter, those will be redistributed according to the number of high acuity bed days in each facility. Now that secondary quality payment, the telemedicine piece, is paid out at the close of the performance year, as I mentioned earlier. So that's once a year, but everything else gives a quarterly payout, which is good because it keeps the money coming in. Again, it keeps the incentive going. Okay. So I actually have another poll because I wanted to ask your opinion. So here's my other polling question. Now that we've been talking about state programs, does your state have some kind of a VBP program? And there's actually 2 yeses because there is a possibility that a VBP program could be mandatory, or that it's in place but it's optional. You can opt in or opt out. If you know that your state doesn't have a program, just say no, or if you don't know, again, these could be programs that depending on your place in the organization, you just might not be aware of, but that you're participating in anyhow. So we saw earlier from the state innovation model program, 38 states have been awarded. So not every state has been is either participating or has been awarded a program, but most states have, because this is really the way to go in the future for both improving quality and outcomes and saving costs. Okay, so let me close this out and share this. So we have another one that's kind of distributed. Is this showing? I'm not sure if this is showing on your screen. It should be displaying. Well, I'll read it out anyhow. So out of the folks who responded, 45% said yes, they do have a program and it's mandatory. Another 18% said yes, but it's optional. 9% said definitely no, and 27% don't know. So appreciate your feedback on that. So I'm going to hide that and we'll move on. Okay, so let me see if I can get my next slide up. I'm not sure if my screen is refreshing, so I'm just going to stop sharing my screen for a second and then show it again. All right, so you should be seeing my section slide here. So just to wrap things up, some general concepts of what I've been talking about, particularly the understanding of the framework, the components of a VBP program, gives you the framework to build on when you are working and managing towards a VBP program and improving and reaping the benefits of that program. And of course, you come from that from your residents reaping the benefits. Thank you, Maria, of that program. So let's talk about the general components of a value-based payment or value-based purchasing program. Firstly, as I said, understanding these components as a framework is very, very important to being successful in that program, because you need to know the rules of the game in order to play. So first of all, is that program mandatory or optional? Are you in whether you chose to or not, or do you have the option to opt in? And if there is an opt-in, what's the deadline to do so? What's the opt-out terms? You know, all the things that you want to be aware of if you are participating in a program. So what's the goal? Of course, fundamentally, this is all about improving quality and then reducing costs. But you know, how are we going to do that? Is the quality improvement measured in reduced rehospitalizations, reduced rates of infections, Other things that would reduce the cost to the Medicaid program in your state, or the Medicare and Medicaid programs for your dual eligibles. Important to know what the goals are, because the goals feed into what measures are being used to measure your performance. How is it funded? So is there something like New Mexico where it's a carve out from the budget and you don't really have to think about it? Is there a percentage withhold like with the SNF VBP program, where they just hold back 2% of your annual payment update from Medicare and then take it from there? Or is there something that is more active, like a bed tax, a provider surcharge, that everybody needs to kick into the kitty and then potentially receive later? What is being measured and how is it being measured? So what's the data? Is this all based on your MDSs that you're doing anyway? Is there something that you need to, in addition, that you need to report to? Other state programs like New Mexico and Texas and California, those are the ones I'm most familiar with, have some form of provider attestation, whether it is that you're participating in a telemedicine program like in New Mexico, or if you have a QAPI infection control program or anything else that doesn't show up in something like your MDS data or your claims, but you have to attest to. Other things like the COVID-19 infection reporting to the CDC, National Health Safety Network, or claims, hospital claims. This is totally something that is coming from outside your facility with the SNF VBP program. So knowing what data is being used to measure you is really important to understanding what your outcome is. And how are you being compared? Are you solely being compared to your peers? Is it all the peers in your state? Are you being grouped according to certain subsets, like a local area or your local rate of COVID-19 spread, for example? Or are you being compared to yourself over a prior baseline period? So you would want to know what that time period is. And you want to know, when does the payment go out? Very, very important. When does that payment go out? Or if there's potential for a penalty, and you think that you're staring a reduction in face, you'll need to plan for that. So when does that occur? Is it once a year, at the end of the year? Is it on a quarterly basis? Are you being paid prospectively, retrospectively? That payment structure is very important to be aware of, particularly for those of you who are doing your budgeting and strategic planning. So as I said earlier, knowing the rules of the game is very important, and also know if and when they change from year to year, because as I said earlier, these measures are ideally made to plug and play so that they can be swapped out for another measure if there's a new area that the payer wants to focus on. So understanding those processes that are driving your outcomes. So how are your data being collected? Particularly your key quality measure items, how are these being completed? Is your supporting documentation giving you the information that you need to code correctly and capture your outcomes accurately? Specifically for the COVID-19 reporting, how are your infection rates being tracked? And how do they make their way into the portal for the NHSN to put in your rates on a weekly basis? Any other key data processes? Very, very important. Do you have more than one person in your building or in your organization that is cross-trained to cover, if necessary, to do that reporting? Because you don't want things to fall behind, or someone who is not familiar with the data that is being uploaded and how it works to be covering for that. Data accuracy is really key. How are you auditing the process of uploading that data for the program. How are you doing it? Of course, for your MDSs, those should be audited anyway because that drives so much, not just a specific VBP program. But how do you do it? Is it an automated process? So using something like PointRight's data integrity audit or another tool? Do you do a manual process? Do you do both? I know MDS coordinators, sometimes we, we have to see it with our own eyes. How frequently do you audit? Is it continuous? Do you do a sample? Do you do 100% auditing? Making sure that that is adequate to make sure that your data are accurate, because having inaccurate triggers like a UTI that was coded incorrectly on the MDS can really skew your numbers. And look at your supporting documentation. How do you audit that elsewhere in the medical record that drives the MDS? And particularly things like physician's orders and those diagnoses for antipsychotics, you know, an antipsychotic medication that's being ordered without one of the three excluded diagnoses of schizophrenia, Tourette's, or Huntington's, that's going to count towards your facility's rate. Monitoring your medication and treatment records and your assessments and care plans, not just for capturing the data that go into those specific quality metrics, but for the whole improvement piece and driving the care plan for your residents. Now, as far as the care coordination is concerned, this is really, really important, not just within your facility, but without your facility, because the whole idea is to improve quality overall, and you need teamwork to do that. So look at your processes for interdisciplinary team meetings. Do you have the right people in the room to talk about the residents? Do you have a specific area that you're focusing on this month? Do you have the right people who are aware of this? How are changes of condition being communicated from shift to shift or within departments or to the physician or nurse practitioner? If there are changes in a care plan, how are those changes being disseminated to the direct care staff so that is being implemented? Because you don't want a delay of a care plan actually being carried out if it's something that is the difference between developing a pressure ulcer and not developing a pressure ulcer. Now, without the facility, of course, things like rehospitalizations and discharges to the hospital from the SNF, transfer documentation is so important. Making sure that the folks in the emergency department, when your resident rolls up in an ambulance, have the information not just of what you think is going on, but what would you like the hospital to do? Do you want them to admit that resident? Do you want them to just work them up, give them some IVs, and send them back? What are you capable of in your SNF to handle? Can really help to bring down those rates of unplanned admissions to the hospital. Also, making sure that you have a mechanism to set up conferences with the hospital staff. If there's an attending physician in the ED or nurse liaison, that you can get on the phone and talk doctor to doctor or nurse to nurse to or nurse to doctor to make sure everybody's on the same page of what you would like done for this resident. And of course, when they come back to you, access to the records for the hospital staff is really important to just make sure that there's not a rebound back to the hospital. With the resident and the family, just making sure that everybody is on the same page and understand fully what the diagnosis and the prognosis is for that resident, and setting appropriate goals, whether it's for rehabilitation and discharge to the community, advanced directives, or anything in between. Now, data correction. I mentioned earlier, making sure you know what time period is being measured for this particular program, what your baseline period is, and how long you have after the end of that period to review and correct errors. That's really important because all of these have a lock time. After the end of that data collection period, you have a certain amount of time to review and correct, but then after that, you're done. So making sure you know when this is going to happen and making sure those corrections are being made and accepted into the database are really important to make sure accuracy of outcomes. So we're getting close on time here, but again, knowing what you're looking at for root cause analysis is really important. If you do find a problem that you need to focus on, get your QAPI committee involved, do your root cause analysis, and that involves knowing the measures, knowing what's driving them, and what time period you're looking at, as I mentioned earlier, and using your data that drives that measures to identify the problem areas, look for your high-risk residents, and focus on those details. So it's basically QAPI in a nutshell. So the PI in QAPI is performance improvement. So making sure that you have the right people on your committee, from the facility leadership, it's because leadership has to have the involvement in the program, your medical director or nurse practitioners or physician's assistants, folks from your direct care staff, resident representatives, family representatives as appropriate, but also depending on what you're focusing on, what your performance improvement project is, you could be bringing in outside resources such as a liaison from the hospital or a specialist or outpatient services like dialysis. They might be involved in the committee for that performance improvement plan. But then it goes straight into the structure of QAPI, defining your goals, what areas you're going to be measuring, sticking to that schedule and your deliverables, and monitoring your progress. So making sure that the leadership is accountable for this process is also really key, because they are often the ones that are in charge of the strategic planning and the budgeting. So if you need something like a change in an equipment vendor, a more responsive diagnostic vendor, or bringing in additional staff if needed, staffing patterns can be very important. I know staffing is a real challenge these days in the pandemic, but making sure that you have at least some backup staff for those care transition times when your new admissions are coming in from the hospital, or as I mentioned earlier, cross training for your COVID-19 reporting is really important, because you don't want to hole in that piece, and you could very well have only one person trained to do that. Particularly care transitions and acute changes in conditions can lead to poor outcomes. So as I mentioned, a SNF to hospital transfer form can be really helpful to set expectations for that transfer. Or how are you communicating the need to revise a care plan if there is a new quality measure trigger? So it's all about communications, whether it's with somebody outside the facility or within your facility team. And just making sure that the education piece, everybody is aware of changes, understand what's going on, what the priorities are. If there's a new program in place, disseminating it to all of the stakeholders is very important. So to wrap things up, it really is win-win when you get down to it, because value-based programs, although they may feel burdensome when you're in the middle of them, it is all about uh, improving value, improving outcomes. So linking payment to quality outcomes can help you make everything better for your residents and your families and your staff, while at the same time lowering costs, which is known in the biz as the triple aim. So the framework of a VBP program is an instrument to help drive improvement and to get rewarded for your improvement. So if you're participating in a program, I hope you're successful with it, because when you succeed, everybody succeeds, if I could be a little cheesy about that. So here are the resources that I have used in this linking to CMS for all of these areas. That COVID-19 performance payment program press release is here. You can look that up. Again, there's not a lot of information published so far on that program. And you can always reach out to me if you have questions afterwards. This is my contact information. And I'm just going to leave this up for the next minute or two while folks are getting ready to leave. This is the link you can go to get your continuing education credit. We will also email you a link to the survey afterwards. The email will go to the folks who have logged in to this webinar. So if you receive that email, please make sure that you forward that also along to anybody who might be attending with you, although that may be limited these days with getting people in the same room. But if you've attended, you can fill out the survey, and please just have it completed by next Friday so that we can report attendance. But it's important to make sure we capture everybody who might have attended with you, because we can only see who is registered for the webinar. We have been approved for 1 contact hour for nurses and 1 contact hour for nursing home administrators. Administrators, please remember to give us your NAB ID number so we can report to the NAB CEU registry. And that is it. I apologize for running over by a few minutes, but I hope this has been helpful to you. I hope you are all doing well and going into the holiday season. I hope you have a good and safe Thanksgiving. Take care.